morning, everyone, and thank you for jumping on today. Today, we are going to address underwriting epilepsy. And if you have been in this business long enough, you've probably heard an agent say, or heard a client say, or maybe you yourself have said, they have epilepsy and this is probably a decline. And we can only look at guaranteed issue or final expense. Today, I would like to challenge that assumption. As it turns out, epilepsy is actually one of the most misunderstood impairments that we see in underwriting. Um, some of the cases are absolutely declines. That is the unfortunate truth. But many of them are insurable, especially when they are properly qualified, packaged appropriately, and placed with the right carrier. That's going to make a big difference. I've said it time and again, not all carriers are created equally. Some are going to be a little bit more lenient with this risk than others. The problem is that most agents either don't ask the right questions, they don't ask any questions at all, they self-decline this case before underwriting even sees it. And that can lead to a lot of lost production, frustrated clients, and missed opportunities. So today what we're going to do is we're going to walk through how underwriters actually evaluate epilepsy risk. What are they looking for? What makes this case viable versus it just being unplaceable? What questions should you be asking in the field? How do we set those expectations with the clients? And then we'll go over a few real world examples. And, my goal here is that when you leave today, you feel confident having conversations with these epilepsy clients instead of just avoiding them or giving up on those cases before we have a full story to look at. So from an underwriting perspective, we're going to kind of start with a quick reset here on what epilepsy actually means in underwriting terms. Because epilepsy isn't one disease. This isn't an official diagnosis. It's a category of seizure disorders. And so underwriters, they don't just care that someone has epilepsy. They care about why these seizures are happening. They care about how often these seizures are occurring. They want to know how well controlled they are. They want to know how predictable this risk really is, and what's prompting that activity. So when we look at epilepsy, there are two broad buckets, basically, of how this works. The first is going to be idiopathic epilepsy. And this basically just means that there is no known structural cause. Um, these cases, they do tend to be more favorable, which I know sounds weird since we don't know the cause. That's kind of an interesting take on it, but they're more favorable because there's no underlying progressive disease that's driving these seizures. So we're not seeing a stroke disorder or a traumatic brain injury or something that we're having to assess that risk as well. And so these are actually more favorable. The second type is going to be secondary epilepsy. This basically means that the seizure is caused by something else very specific. It could be head trauma, it can be a stroke, it can be brain tumors, infection, congenital abnormalities. These are going to automatically get more scrutiny because of that underlying condition adding its own specific risk. So that's kind of the first two buckets that we look at when we look at epilepsy. Is it idiopathic or is it secondary? Do we know the cause? What risk are we up against here? Once we kind of narrow that down, the next thing we're going to look at is the seizure type. If you've ever had an epileptic case, you'll know that's one of the number one things that the carriers are going to want to know. When it comes to generalized seizures, this is where we see a loss of consciousness. This is also where we see the higher risk of injury and ER visits and such. The one I think most people think of is going to be the tonic-clonic or the grand mal seizures. This is where there's stiffening of the body followed by those rhythmic jerking movements, and oftentimes we'll see loss of consciousness there. Then there is the petit mal, which is kind of those brief steering spells. They appear to kind of space out, zone out, don't hear or remember anything that just happened. Um, that's that's going to be a very different type of seizure, especially just from a visual perspective. And then there's clonic movements, which is that rhythmic jerking on both sides of the body. There is tonic, which is just sudden stiffening of the muscles. There is atonic or drop seizures where they just have a sudden loss of muscle tone, and this can cause falls, which obviously is going to increase your injury risk. Well, all of these really kind of increase your injury risk, but and then myoclonic, which is the brief shock-like jerking of the muscles. So in generalized seizures, this is what we typically see. This basically means the seizure is affecting the whole brain, whereas in comparison, we have focal or partial seizures. These are oftentimes more mild. They're a bit more predictable, and they are usually only affecting one side of the brain or one portion of the brain. In these situations, for the focal seizures, people typically stay more aware. It may involve some jerking movements or sensations. It can come with very heavy emotions, uncontrollable crying or laughing and such. There's also the focal impaired. This complex partial seizure, the awareness is clouded. The person may be staring blankly off into space and having repeated movements, like maybe picking at their clothes. They have no memory of the event. The event is kind of lost to them. Or we also have the focal to bilateral, which is where it starts focally, but then it spreads to both hemispheres of the brain. So it starts focal, but then it becomes generalized into a tonic-clonic type seizure. So when we are underwriting this, one of the things we always ask is it generalized or focal? Do we know the cause or do we not? And then we want to know what type of seizure they're having. That is going to make a big difference in an underwriting perspective, and how that's what kind of risk we're looking at, what kind of tests we might want to see, so on and so forth. All right, so some of the things the carriers are also going to care about. They want to know the age of onset. Is this a child? Is this something that's congenital? Or oftentimes in children, we'll see this with infections or really high fevers. Is this an adult? Did this, begin at at a later age? And how long has it been stable? Is this something that they've had controlled for many years, or is this something where they're having seizures every month? Um, what is the stability there? That's going to help determine how risky the situation is. They also want to look at medication response. There are a lot of different medications out there, and oftentimes it does take changing those medications or increasing or decreasing dosages just to, get everything stable and under control. So they want to see that response to medication, um, recent changes, so on and so forth. And then compliance. Compliance is key because a lot of people can go for many months or years or weeks with no issues, but if you're not compliant with your med, you're more likely to see breakthrough seizures. And so something that underwriters definitely look at is compliance. And 15, 10, 20 years ago, compliance wasn't always really obvious by reading through medical records because, clients could say, yeah, I take it almost every day. And in their minds, they really believe they do. Um, but then, now today we get these background reports and these pharmaceutical reports, and compliance is very obvious now. If those prescriptions are not being refilled on a regular basis, we can see when the compliance is not there. So that's just my own little interesting take on how things have kind of changed over the years when it comes to underwriting things like compliance. We can really verify that more now. So the biggest theme you're going to hear today, or that you've heard so far and will continue to hear, is that we care about control and consistency. Those are the two biggest factors. It's not just that diagnosis. All right, so what actually drives the underwriting decisions? When a case hits underwriting, we are already scoring that risk across a few key areas. So one of the main drivers is going to be, first and foremost, when was the last seizure? this is definitely one of the biggest factors. If this client has been seizure free for over 5 years, that's when we're going to see our best possible income or outcome. That income. Um, this is going to show us that yes, they are compliant. Yes, they are good with their follow-ups. This is stable. There is not as much of a risk as somebody who is having seizures every day, obviously. So that's going to be our best possible outcome. Seizures, for if they've been free from seizures for the last 2 to 4 years, this is obviously still very, very good. We can sometimes still see a couple of table rates on this, that table two range. It depends on why they may have had a seizure in the last 2 to 4 years. Let's say they've been completely stable for 10 years, but 2 years ago, they had some breakthrough seizures. And, if we know the reason, like there was a high fever, or maybe it was flashing lights during a movie, knowing what triggered that can make a big difference in whether or not we see table rates here. If we don't know what triggered that breakthrough seizure, that's going to be seen a little bit more risky than if we do know the reason. So as clients are telling us their history, the more details we can get, the absolute better. If they've had a seizure within the last 12 to 24 months, this is where we start to see the postpones and the declines. Obviously, again, it's going to come down to why they may have had a seizure. If we know the reason for the breakthrough seizure, then that is going to help us immensely. If we do not know the reason, or they just, they occur every few months, and we just can't get those under control, that's when we're going to see those postpones. The decline is going to depend on a lot of those factors. And then obviously, if we are seeing ongoing frequent seizures that are uncontrolled, or there's not compliance, those are going to be declines for sure. One of the next big things they're going to look at is medication stability. As I stated before, a stable medication regimen is key and keeping those breakthrough seizures from coming away, and having everything under control and mitigating that risk. In the beginning, there are oftentimes different medications tried, dosage changes. So we're looking for a client who's gotten to a point who has no frequent dosage changes or medication changes. We want to see that what they're doing is working, and it's consistent, and it's stable, and we want to see good compliance. We want to know they're not putting themselves or others at risk by not taking those meds. And then we want to see minimal side effects, just impacting daily life and function. If you're having horrible side effects with the medication and constantly changing those or needing to change those, that's where we start to see those postpones again. All right, again, touching back on the breakthrough seizures, they're going to look at how often that happens, what triggers those, whether or not they required ER visits, and whether or not any injuries occurred. If they're having one of the lesser seizures and just kind of staring off in space, that's not going to be as risky to the person themselves, not having any falls or injuries from the clonic tonic movements. And so it does make a difference whether or not they had to be seen, whether or not there were injuries, how severe that was, and again, what triggered it. Was it totally random and no explanation? Or were they watching a movie that had crazy flashing lights and set something off that, hadn't happened in years, but now here we are. So definitely want to dig into that. A breakthrough seizure after years of control can absolutely still be workable. Don't think they can't be. It's just that those patterns and the reasons really matter. And we're going to want to look at all of that. And then again, underlying causes. Those idiopathic cases, they do typically underwrite better than the secondary causes. Again, I know that just sounds really weird. You would think they would want to know the cause. And yes, of course, we want to know the cause, but oftentimes the causes are things like brain injuries or tumors or stroke or neurodegenerative diseases. And those come with a whole nother set of risk factors on their own that we now have to underwrite and dig into. And so, it kind of amplifies the risk. And so that is why the idiopathic cases just typically underwrite better than the secondary ones do. And then we are also going to look at lifestyle and safety exposure. The underwriters, they're going to want to know, are there driving restrictions? Has your license been taken away? Oh, and by the way, have you, still been driving even though you're not supposed to? um, Occupational risk. Are they working at extreme heights or with heavy machinery? That's obviously going to add risk if somebody's having seizures, especially like the breakthrough seizures, or they're not controlled. Are they a commercial driver? A lot of times those licenses will be taken away if you're having these breakthrough seizures and such, or the epilepsy is not well controlled. So these are things that the underwriters are going to dig into a little bit more. They don't always mean it's going to be a decline. Please don't ever assume that, because I could see a case that states the guy has epileptic seizures, and oh, by the way, he's a roofer. Well, that's going to probably raise a few red flags, because he's obviously at an elevated height up on top of a slanted roof. You have a higher fall risk, and now you add seizures on top of that. However, digging a little bit deeper, we find out, yes, he owns a roofing company, but he does not actually get up on the roof. He is the foreman. He, uses a drone to see what's up there. So maybe that risk isn't actually elevated. We need to dig into what they're actually doing, what their job duties are, what restrictions have been placed on them. So again, not always a decline, but it can impact the rating. It can add a little bit of extra risk. It may add a flat extra, or it may add a table rate, or it may not. It may be perfectly fine once we dig into some of those details. And then one of the biggest reasons we do see declines is for lack of follow-up care and compliance. Um, the underwriters are going to want to see regular neurology visits. They're going to want to see up-to-date testing, documented stability. A client saying, no, I felt fine, I haven't been back to the doctor in 2 years, that's not going to cut it. It has to be documented stability. We want to see that they are taking care of themselves and following up the way their doctor has advised. Medication adherence matters. Again, consistency, compliance, all those things. Um, but this is why the detailed field underwriting really makes or breaks these cases. You can find a lot of these things out just by talking to your clients. Some of the more common tests that we're going to want to see are ones that obviously the neurology visits should cover. And so if these are not taking place, this is where we're going to start seeing postpones or declines until they are up to date. We need to make sure that they're getting everything checked out the way they're supposed to, that they're not adding any additional risk to themselves by not following up appropriately. So some of the more common tests that we are going to want to see, or that the underwriters may ask for, first is going to be like a routine EEG. This is where they put the electrodes on the scalp and they record the brain waves in a clinic. This oftentimes will involve sleep or flashing lights to kind of trigger an activity, maybe hyperventilation. But this is so they can record those brain waves and really figure out what's going on there. There's also an ambulatory EKG or EEG, which is a portable device that can be worn at home for a few days. This records the activity during normal life. This helps them to also figure out what's triggering it. These are especially useful when seizures are not visibly apparent to the rest of the world. Where the seizures where they stare off into space and such. This is where they can pick up some of those brain waves and figure out what's going on and what's triggering that. Um, Other imaging that they may request be an MRI. These are detailed images that are used to find those structural issues like tumors or scars or more malformations. And when that's not available, a quicker, more X-ray based scan like a CT scan can be used. This is more often like in emergencies when an MRI isn't necessarily suitable. Could be as, in an ER visit, you're more likely probably to get that CT scan during an emergency situation. This will show tumors or bleeding on the brain or any kind of cyst. So those are very common ones that we see requested. Others that we might see come up are going to be blood tests. Oftentimes, they want to check for infections, diabetes, electrolyte imbalances, or just any other condition that could be causing or mimicking these seizures. Um, an ECG, an electrocardiogram. I know oftentimes we think, that only relates to the heart. Well, the heart can also relate to seizures. So this rules out any heart problems that can look like seizures. So that would not be uncommon to be requested. And then genetic testing. This is oftentimes requested in children just to rule out any kind of genetic issues there. So when it comes to underwriting this in the field, this is where a lot of agents kind of struggle. They just don't know what questions to ask. So here's some simple framework. You can use it on every epilepsy case. Just start with that seizure history. Find out when was the last seizure. How many seizures have you had in the past 12 or 24 months? What type of seizure are they having? And are they losing consciousness? Have there been any injuries, etc.? Next, let's see if they know the cause. Do they know what's causing this epilepsy, or is it completely idiopathic with no explanation? Was there a head injury? Was there a stroke? Was there a tumor? Was there infection? Was there fever? What do they know? What can they tell us about that cause? Medications. What medication are they currently taking? How long have they been on that same dose? Have there been a lot of recent changes? Are there a lot of missed doses? Have they changed medications 5 times and this finally might be the one, or they still don't know? Um, and then stability in care. Are they seeing a neurologist on a regular basis? Are they seeing their primary care physician on a regular basis? If they've been recommended to have any additional testing, have they done that? Are they following through on those recommendations? Again, any ER visits or hospitalizations that have occurred from this. Find out when, find out how long that's been, find out how severe it was. And then also any injuries from that seizure. And then lifestyle. Lifestyle is going to matter as well. Are they okay to drive? Are they driving when they're not supposed to be? Are there any work restrictions? Are they using heavy equipment when they've been told they probably shouldn't? Just any safety sensitive job duties. Um, and I know I say it all the time, but the more we can get up front, the better. When we skip these questions, then the underwriters end up chasing the medical records. It delays the cases, or it just declines due to uncertainty. If they can't get the answers, then that's when they won't make an offer. So the more we can provide, the better our success is going to be in that placement. Um, and then to success with these hard to place cases, it's oftentimes also about how we frame that expectation with the client. Um, we should never promise preferred or even standard up front. Instead, try just saying that it can absolutely be insurable, but the rating does depend on how well controlled it is, how long it's been stable, what's caused it. And, our job, your job in the field, my job here is to present that full history so that underwriting can evaluate it fairly. So just let the clients know up front that yes, table ratings are common. Yes, flat extras are possible. Some carriers might postpone or decline this, but options do oftentimes exist. If you can lay that out up front, it prevents any surprises. It's going to build credibility. And if we shop these in advance and get ahead of it, we can make sure that we go to the carrier who is willing to consider it and not the one that wants no part in it because they're a little bit more risk adverse. So let's dig into just a couple case examples. Just got a few quick and easy ones here. Case one, 45-year-old gentleman, idiopathic epilepsy, no idea why it's happening, but he's been seizure free for the last 6 years. He's been on one medication. It's been very stable. He hasn't had to make any changes on it. He does see his neurologist on a regular basis just to make sure there's no changes in his brain. No driving restrictions. I mean, everything's going great. You wouldn't even know he had it probably. This case has a very strong chance of standard, maybe a mild table rating depending on the carrier. But for the most part, we should have no problem finding a home for this gentleman. Case number 2, we've got a 52-year-old female. She did have a breakthrough seizure 18 months ago. The medication was adjusted afterwards, but since then it's been fine. It's been otherwise stable. There were no problems leading up to that. There were no injuries. Her life has been pretty normal and consistent with her medications and her regular follow-ups. In this situation, due to that breakthrough seizure, we are a little bit more likely to see table ratings, possibly a postponement depending on the carrier. Um, but again, this is why we shop the case. This is why we get the information up front and we pre-screen it to see who's going to be a good fit. And then case number 3, we run into a 38-year-old gentleman who is having multiple seizures annually. He is not good about taking his medication. He has had several ER visits. We do know that the cause of his seizures are due to a head trauma. And unfortunately, this case right now here today is going to be a decline. It's not necessarily a permanent decline. If he becomes compliant with these medications and the seizures stop and he starts seeing the doctor as he's recommended to, um, if we're not having the seizures, we're not having all the ER visits, there is a level of control that can be reached so that coverage is possible again. So it's not necessarily permanent, but today, for all intents and purposes, this young man is unfortunately a decline. So to take away today's pretty simple. I think epilepsy is not an automatic decline. It just demands good field underwriting and setting realistic expectations. If you're unsure about a case, please do not just give up on it. Gather the facts, send it in to us for us to shop in advance. That's absolutely what we're here for. Um, there's a few different ways that can happen. I have case studies galore. I shop cases all day long and I keep all those details and can go back and look and see exactly which carriers have been the most competitive in certain situations. We also have these wonderful fact finders out on our website. There's this very generalized health screening questionnaire where you can kind of touch on everything. If you're meeting with the client for the first time, you want to send it to them in advance to get an idea what we're up against. And then beyond that, we have very ailment focused questionnaires. For this in particular, there is an epilepsy questionnaire out there that I can send you, and it'll have all these questions on there so you can dig in with the client and get the information that we need. Gather those facts, send that back in to me, send it to your sales director. Either one is fine. Either way, I'm going to get it and we can shop that out. We can figure out who's going to be the best match for the situation at hand. Shopping these cases is easy. You can call me. You can email me at andrea@iamsinc.com to discuss, the history. Again, the more details, the better. You can give the information to your sales director and they'll get it over to me. We can do a conference call with all of us and figure out, case design and all these things. But these questionnaires, they are available on the website. I can also email them to you. Your sales director can email those to you. So send it courier pigeon. That's fine. As long as it gets to me, I'm going to shop it out. And with that, I certainly do appreciate you joining us today. Don't forget to follow us and like us on LinkedIn and Facebook and all the socials. And I really hope everyone has a great week, stays warm, stays safe, and thank you so much for your time. Take care.